Morphea is a form of localized scleroderma. Scleroderma literally means hard skin. Although it is often referred to as if it were a single disease, scleroderma is really a symptom of a group of diseases that involve the abnormal growth of connective tissue, which supports the skin and internal organs. Morphea is a condition that can cause a wide variety of problems, from skin discoloration and thickening to difficulty with the function of joints, muscles, and other connective tissues. The appearance of morphea is that of a well-defined ivory-colored plaque with varying degrees of inflammation around its borders. It generally starts as a reddened area. The center gradually becomes white or yellow in color. There can be a lack of hair noted, and sweating may be reduced depending on how advanced the lesion has become. Some of the most common types of morphea include circumscribed, generalized, linear, and mixed. Circumscribed morphea has an oval/round shape and affects the deeper tissue. Generalized morphea has 4 or more lesions larger than 3 centimeters on 2 or more anatomic regions. Linear morphea has a band-like thickening or plaques that form a linear pattern and involve deeper tissues. Lastly, there is mixed morphea. It has presence of lesions consistent with the definition of linear morphea, plus either plaque or generalized lesions concomitantly.
The cause of morphea is unknown. Researchers are trying to determine what triggers the disease and whether it is genetic in origin. It is believed that the immune system has a role in causing the disease, but it is yet to be classified as an autoimmune disorder. Morphea is not contagious. The onset of morphea may be related to radiation therapy, repeated trauma to an affected area, or a recent infection such as measles or chickenpox. Symptoms of morphea include hardening and thickening of the skin, discoloration, oval-shaped patches that may gradually develop a whitish center, linear patches, especially when on the arms or legs, and loss of hair and sweat glands over time in affected areas.
There is no cure for morphea, but treatment options are available to control the symptoms produced by the disease. One type of therapy is light therapy. Light therapy is a special treatment that uses ultraviolet light to improve your skin's appearance, especially when used soon after skin changes appear. Another treatment option is a type of cream. This prescription cream is a synthetic form of vitamin D that may help lessen the effects of morphea. Skin generally begins to improve during the first months of treatment. There are also various medication options your doctor can prescribe for you. Your doctor may prescribe corticosteroids early in the course of treatment to reduce inflammation and prevent thickening of the skin. There are also anti-malarial drugs. Medications such as hydroxychloroquine may be used to help reduce inflammation and slow the progress of the disease. Lastly, there are immunosuppressive medications. Your doctor may prescribe drugs to control your immune system and reduce inflammation. However, these medications can have serious side effects, including increased risk of infections, kidney and liver problems, and high blood pressure. A final treatment option is physical therapy. This type of treatment uses stretching and strengthening and range of motion exercises to improve the mobility of your joints.
About 25% of morphea patients will have at least one extracutaneous manifestation, but less than 4% of morphea patients will develop more than 2 non-skin manifestations. Approximately 2% of morphea patients have anti-centromere antibodies, which means that they may be at risk for eventually developing systematic scleroderma. Systematic scleroderma not only includes the skin, but also involves the tissue beneath, the blood vessels, and the major organs. It is very common for morphea to occur along linear scleroderma, since they are both forms of localized scleroderma. Morphea has been known to occur in patients who also have linear scleroderma, T-cell lymphoma, pemphigus, primary biliary cirrhosis, systematic scleroderma, toxoplasma gondii infection. Also, associated skin diseases include vitiligo, ichthyosis, and etc.
Caucasians and people of Asian descent are more likely to develop morphea than African Americans are. Morphea is more common in women than men, and about half of all patients first show signs before the age of 18. There is very little information about who is at highest risk for getting morphea, as there is no known predictors for the disease. Other autoimmune diseases are more common in patients with morphea, and possibly their relatives as well.
So in 5th grade, I got the chickenpox shot, and my arm swelled up pretty bad, and it stayed like that for a while. A few months later, I had noticed tender spots near the joint on my elbow and in my underarm. I would go to the doctor a few times, and they figured out that it was morphea. They gave me a few treatments like cream and tape to put on it at night, but none of it worked. I still have morphea to this day, and that's my story.